You know a bit of my history, but if we get the listeners up to speed. So my dad had a heart attack at 41, 42. And prior to that, he didn't have, a diagnosis of cardiovascular disease. He wasn't taking lipid-lowering drugs or blood pressure-lowering drugs. Those. By the way, Simon,
I'm going to cut you off for a second.
Sure.
As soon as you say my dad had a heart attack at 41 years old,
we don't need to go any
further. We do, but I've already in my head started the process of thinking about, boy, we need to really protect this guy. To me, that's a red flag for high risk. So I'm glad we're talking about this. But I want you to know that I've already sort of in my head thought to myself, this is someone who would probably benefit from pharmacotherapy as well as a healthy lifestyle. Sorry to interrupt you.
No, of course. So that came out of the blue. He wasn't on any of these medications, and even after the heart attack, his cholesterol wasn't crazy high, his blood pressure wasn't crazy high. These were pretty much average for someone of his age living in Australia. We don't have high Lp(a). Both of us have had that tested. It's negligible. Which is great. My LDL cholesterol, going back to tests that I could dig up, I believe was around 110 to 120 milligrams per deciliter for the better part of 30 years. And then when I was 30, I changed my lifestyle a fair bit. I started eating a diet that was much higher in fiber, unsaturated fats. So not a low total fat diet, just low saturated fat, lots of unsaturated fats. And was able to get my LDL cholesterol down to around 70. And my ApoB, it hovers around that. Sometimes it can be in the 60s, sometimes low 70s. So that's where I'm kind of sitting today, without high blood pressure, without poor metabolic health and signs of insulin resistance, anything like that. Triglycerides seem to be optimized. HDL is good. Am I someone who should be doing imaging to see what's going on in the heart and or carotid arteries? And would I be a candidate for lowering ApoB with medications? And how would we determine kind of how low we would want to go?
You're a tough case. I'm going to have an answer. But I will tell you that I'm sure you could, if you saw 10 different people who do what I do for a living, you'd probably get a wide variety of responses. Did you say what your LDL cholesterol pack year history is? Did you calculate it?
Well, I can do some numbers off the top of my head. I mean, it's well north of 3,000. It's probably approaching 4,000.
I thought I was going to stump you there because I honestly, I don't know how to calculate LDL pack years. That's what I was getting at. Earlier, you asked me about that.
Well, I just calculated, let's say I averaged 120 over 30 years, 120 by 30 is taking me over 3,000.
And then you factored in that since 30,
I had it lower.
Yeah.
They were rough numbers. Yeah. Not a mathematician.
Exactly. So you're someone who actually has a lot of the data, so you can do things like that. And that probably has some value. And of course, this is going to be an LDL cholesterol based response because I guess you only have ApoB in the more recent past, and we don't know what your ApoB level was before you made those changes. But it sounds like it's concordant now, and presumably it was concordant before. So you probably did not have a very high ApoB level, but you certainly have a high enough ApoB level and LDL cholesterol to generate atherosclerosis. So it's fantastic that you made the changes that you've made, and what you've achieved by lowering your LDL cholesterol that much is probably clinically significant. That it goes beyond just the LDL cholesterol lowering. So there are probably some direct health benefits to having made those changes that improve endothelial health and maybe improve blood pressure, and that go beyond just the LDL measurable factor that's there. But remember, you can develop atherosclerosis still with levels where you have, and it still can progress. And the amount of LDL cholesterol lowering that you've achieved is similar to what you would get with a moderate intensity statin. And a moderate intensity statin in a young person should offer good protection over the course of the rest of your life. So I think it's arguable that you've done enough, that if you just look at the evidence available from randomized placebo-controlled clinical trials, that you can say, bravo, keep up the good work, make sure you stay on this plan, don't make any changes, don't use any pharmacologic therapy to reduce your risk further, and that's adequate. On the other hand, you may also have significant atherosclerosis that you're incompletely treating, because we know there's residual ASCVD risk simply on the basis of your LDL cholesterol at this range. And we know that because we have multiple clinical trials in primary and secondary prevention that show us that when you lower LDL cholesterol that much, there are still people who go on to have cardiovascular events. So you can potentially enhance your outcome and reduce your chance of having cardiovascular events by trying to achieve LDL cholesterol levels that are more akin to wild animals. LDL cholesterol in that sort of 25 to 50 milligram per deciliter range, as opposed to in the 70s where you are now. Levels
ApoB in a similar ballpark.
Same ballpark, yeah. Levels that have been achieved in randomized placebo-controlled trials now with non-statins added to statins. So would you potentially benefit from pharmacologic therapy to get you down into that range? I would add one more thing about which pharmacologic agent. So I was trying to be generalist about this, but back in the 90s and the early aughts, the industry sort of recognized that statins seem to lower cardiovascular risk more than you would have expected based upon their LDL cholesterol. And there were biological properties that were identified with bench research. And as far as I can tell, they invented a word that I have never heard used with respect to anything else, which is the pleiotropic effects of statin drugs.
That's a great word.
It's fantastic. I have no idea what it means other than some magical property of the drug itself.
Right.
Do you know that if it means something else? Yeah.
Well, I think pleiotropic means it's having multiple effects, other effects.
Okay.
Yeah.
Yeah.
I think that's what pleiotropy means, but I mean, someone can fact check me. I think it means that it's not having an isolated effect. It's having multiple effects, different mechanisms, something like that.
Yeah. That's how I understand it too. And so it is possible that just like you can have pleiotropic effects from the dietary changes that you made, I'm sure that you did more than just lower your LDL cholesterol by making those changes. I think it's possible you could have some pleiotropic effects from statin drugs. I don't hang my hat on that. I just bring it up as a notion that is, maybe I'm dating myself by even mentioning it, because I think one of the things that we learned ultimately with something called the cholesterol treatment trial is meta-analysis of all the statin trials. So if you heard of the CTT analysis, came out of Europe, where the European group looked at all the big RCTs, and they showed that there's a roughly linear relationship between LDL cholesterol lowering achieved and relative risk reduction when you looked at all of the big landmark clinical trials with statin drugs. And there were 26 of them in this meta-analysis. That's a huge meta-analysis of clinical trials. And with such a strong linear relationship, which by the way has been done with non-statins now, and all of our non-statin therapies fall on the same line, same regression line.
So no matter if you use a PCSK9 inhibitor or bempedoic acid or a statin, for every milligram per deciliter reduction in LDL cholesterol achieved, you get the same risk reduction.
Exactly.
Which tells you that these are all acting via the same mechanism.
It seems to be that the main mechanism is there's less LDL in circulation. So if there's a magical property to statins, I don't know what it is. I think the real magic is the abundance of clinical trial evidence compared to Ezetimibe, compared to PCSK9 inhibitors, compared to bempedoic acid. 26 major clinical trials, landmark clinical trials, assessing whether statin versus placebo reduces risk or high intensity versus moderate intensity statin reduces risk.
I think the more I've had conversations on this as well, I've been able to kind of reassure myself that a lot of the fear that can be generated online about lowering LDL cholesterol, some of it is certainly warranted, but some of it seems to be unwarranted in that you'll see people making claims that, Simon, don't take lipid-lowering drugs because you need that cholesterol to synthesize hormones, like you mentioned before, not understanding that all cells are producing all the cholesterol they need for that, and that knocking cholesterol down in the blood, at least to my understanding of the conversations I've had, even to very low levels, isn't going to affect the production of these sex hormones, for example, or isn't going to affect the cell membrane where cholesterol has an important role, because those things are dependent upon cholesterol synthesis inside the cell, not pulling cholesterol out of circulation.
Yeah, reducing the LDL in the circulation, not reducing it in the cell.
I mean, that just seems to be a misunderstanding of physiology. I kind of understand how people can jump to that conclusion, right? Cholesterol is important for hormone production, therefore you shouldn't lower in the blood, not understanding that these are like separate compartments. And then the other one is brain cholesterol synthesis, which I recently had a very long discussion with Dr. Dayspring on. And that, again, was reassuring for me that brain cholesterol synthesis is separate to peripheral cholesterol synthesis, both in the liver and in peripheral cells, and that these lipoproteins aren't even, for the most part, crossing the blood-brain barrier. So that's been very reassuring. What would be the major side effects that could be seen from lowering my LDL cholesterol down even further from say 70 down to 30?
I don't think there's any side effects from lowering the amount of LDL in the circulation. But I do think that some of the medicines have specific potential side effects, and it's not related to lowering the LDL cholesterol. PCSK9 inhibition, I'm highly confident, does not have any major risks to our physiology. It directly affects LDL receptor recycling. And I don't know yet whether it does anything else beside that. But it so far seems to be its main mechanism and the only one of import. And I can't find a reason to be concerned about that. Now, there is a difference in side effects in people on drug to inhibit PCSK9 compared to people who are on placebo in clinical trials. But the side effects are nuisance ones and minor and hardly worth repeating. And they're different between the monoclonal antibodies versus the siRNA therapy. So I start with the easy one. That's because I think PCSK9 inhibition seems to be the easiest one because it mostly just reduces the amount of LDL in the circulation and it's not affecting cholesterol synthesis.
So is that where you would start with someone like me if I was saying I'm down for getting my LDL cholesterol down?
Yeah. So no, because we live in a real world where these things cost money. And the current standard is to start with statin therapy because of the wealth of evidence and that taking statin drugs reduce cardiovascular outcomes in a wide range of patients, people who have established heart disease, people who don't have established heart disease, but they have major risk for heart disease because they're diabetic and hypertensive, and people who have high levels of LDL cholesterol or people who have more moderate levels of LDL cholesterol but have other features like an elevated HSCRP. So the wide range of patient types, a wide range of LDL cholesterol starting points, we learned in the early 2000s that in patients with established heart disease, it doesn't matter whether you have a high LDL cholesterol, a normal LDL cholesterol, or a low LDL cholesterol. If you have established heart disease, you will reduce risk by taking a statin drug. So we know that we can reduce risk. So what's the downside? Well, they're quite safe. I'm never concerned about causing an irreparable, irreversible problem by giving somebody a statin. But they're not that well tolerated, and they've got a terrible reputation. As all you have to do is turn on the interweb to find out what their reputation is, and you'll see people giving all their opinions about statins do this, statins do that, and some of the things that you mentioned are legitimate, but there's lots of magical thinking about what statins do. And the reputation of statins is powerful, and it's hard to fight against that, but they're quite safe. I have some concerns in people who perform exercise at a high level, especially if they're making their living that way. So athletic performance, which is sensitive to subtle changes in musculoskeletal function, I would be a little concerned about, maybe starting somebody as their principal therapy being statins. But if you do recreation and exercise for health and fitness and well-being, and you're not making your living at that, the side effects are nuisance and dose dependent. So we can find a dose that works well for our patients who are in that category. And that's the most common side effect, right? The musculoskeletal side effects. So and by the way, I forgot to mention, they're guideline based and they're cheap as dirt. They're basically given away. There's the only companies that are making money off of statin prescriptions are the generic companies that manufacture them. I assume they make money off of them, but there's no branded statin therapy that we use. So
right, there'd be more money to be made by selling PCSK9 inhibitors to everyone.
Of course.
My go-to brand for all things protein and creatine is Momentous. To help reach my daily protein target, I complement my diet with 1.5 scoops of Momentous's chocolate or vanilla chai plant-based protein for 30 grams of protein and all essential amino acids, which supports muscle growth, hormone and collagen production, skin health, and recovery. I also consume 10 grams of Momentous's creatine daily to enhance energy production, muscle strength, bone health, and cognition, with studies now showing the benefit of creatine on short-term memory and intelligence. I'll do anything for a little extra brain power. Both products are NSF certified for sport. This certification is the only third-party certification program trusted by the NBA, MLB, Ironman, etc. NSF certification means you can rest easy knowing you're actually getting what's on the label and nothing more. So if you're interested in making a true investment in your health, why not join the best in human performance and be a part of the change in raising the bar on supplements? Simply go to livemomentous.com and use the code LIVINGPROOF for 20% off your new routine today. That's livemomentous.com with the code LIVINGPROOF. Where do ezetimibe and bempedoic acid land?
Well, I think ezetimibe is sort of your next option. Like let's say, for example, you were hoping to achieve a 50% LDL cholesterol reduction, or you wanted to target an LDL cholesterol level between 25 and 50 because of your family history of coronary artery disease. And so you get to a certain level by taking your statin, and you're like, boy, I don't think I can, exercise at the same level on the dose that Dr. Safar recommended for me. So I'm going to take a lower dose. And on your maximally tolerated statin, you're not quite at the range. But you can eke out another 18% LDL cholesterol lowering by adding ezetimibe. And, I've heard Tom on your podcast talk about how, ezetimibe inhibits, sterol absorption that goes beyond just cholesterol, and talked about the potential downside of, phytosterols as a toxin. And, Tom was one of my teachers, and I feel persuaded by everything he says, of course. And so I give credence to that. But the clinical trial evidence for the benefits of ezetimibe is modest, but maybe significant. we didn't talk about the impact of low-level LDL cholesterol reduction over a long period of time that we think about in our highest risk patients that we need to achieve big LDL cholesterol reduction. The more plaque you have, you need to drive that down really low. But we know that from observational data, Mendelian randomization data, that if you inherit gene variants that lower your LDL cholesterol by a small amount, that when you're 50 years old, you have a reduction in risk for cardiovascular disease compared to your cohort that can really only be explained after multivariate analysis due to that LDL cholesterol lowering. So a small dose reduction in LDL cholesterol for a long period of time can go a long way to improving your cardiovascular outcome. And when you compare that kind of thing, Brian Ferentz and the group from the EAS did this. They looked at the same amount of LDL cholesterol lowering achieved with drugs in clinical trials. It dwarfs what you can achieve in those 3 to 5 year, maybe 7-year clinical trials. So long-term exposure to even modest LDL cholesterol lowering has an amplified effect over time. That's that cholesterol pack years that you can achieve from a genetically inherited variant.
So for someone like me, if I've come to the conclusion where, I'm going to take a low dose, low intensity lipid lowering drug to try and get me into 30 to 50 milligram per deciliter range, physiologic level, so to speak. Is there any benefit for me to go and do a CT angiogram, or is that just for academic purposes and interest sake? Or do I just start lipid lowering therapy knowing that I have such a high risk, family history risk, and not play around with it?
We're outside the box here, but I think you appreciate outside the box thinking. I'll start inside the box first, though. So the American Heart Association offers some recommendations that are really foundational care for atherosclerotic cardiovascular disease. And they refer to it as Life's Essential 8. It's got a catchy title and a cool infographic that really sort of simplifies things. But these are things that you already know. And when you're talking about the foundational care, the pharmacologic intervention for people with atherosclerosis is on there. But it's, the list is, eat a heart healthy diet, exercise regularly, maintain a healthy body weight, make sure you manage sleep and stress. Not sure how to do that exactly, but do that. Don't smoke cigarettes, keep your blood pressure excellent, lower your LDL, and optimize glycemic control. Other parts of foundational care for people at high risk also include, and now we're beyond Life's Essential 8, but also include antiplatelet therapy. So if you have a lot of atherosclerosis, we use antiplatelet therapy. We put people on aspirin therapy if they have established atherosclerotic cardiovascular disease. There's evidence from imaging studies that suggest that if you have a high plaque burden, your risk for cardiovascular disease starts to look like those of people who with established heart disease, and what the justification may be for using antiplatelet therapy. So rather than classifying everybody who's never had an event as primary prevention, thinking about subclinical atherosclerosis on imaging as a tool to understand who in that category has high enough risk to warrant other things like antiplatelet therapy. The risks from aspirin therapy are higher than that from lipid lowering therapy. Like, I don't have to talk about an irreversible...
They like bleeding risk?
Yeah, bleeding risk. And
hemorrhage, stroke.
It's usually, hemorrhage, cerebral bleeding is the worst case scenario, but gastrointestinal bleeding is probably more common. Young, healthy people have very low risk for bleeding from antiplatelet therapy. The older you get, the higher the risk. So it's a little different if a 75-year-old says to me, hey, should I do an imaging study to see how much plaque I have so it can inform me about whether to use aspirin? Now you're into some, tough territory, because even if I find that person has plaque and I wish I hadn't looked, now I'm faced with this tough decision of should I use aspirin therapy in that population? And that's where the risk of bleeding from aspirin starts to go up. But if I know they have a high plaque burden, I will recommend aspirin.
Yeah, I think my dad who's almost 70 now, has been on aspirin, a statin of some type, and PCSK9 inhibitor.
Yeah.
The three of those.
So he has established heart disease and he's done great, right? He hasn't had any events since 41 years old. So, it sounds like he's doing well, and presumably he does not have significant progression of atherosclerosis. We have other therapies, though, that reduce risk for people with cardiovascular disease. We have evidence now that taking semaglutide, if you are overweight or obese and have atherosclerosis, reduces your cardiovascular event rates. We have evidence, there's conversations about how strong this evidence is, but icosapent goes by the trade name Vascepa, reduces cardiovascular event rates in people with established cardiovascular disease and high triglycerides.
It's 4 grams of EPA.
Exactly, yeah. 2 grams twice a day with food. And then we also have evidence for the use of colchicine. At low dose colchicine, which is an anti-inflammatory therapy, reduces cardiovascular event rates in people, regardless of whether we know that about their inflammatory status, although it probably should be reserved for people with evidence, some sort of serologic evidence of inflammation. It's a complicated drug and its uptake has been slow, but this is sort of the latest in our armamentarium. I'm not suggesting that a high calcium score would necessitate these non-foundational therapies, but I think it's something to think about in our patients if you're really trying to optimize care, that we sort of think about all the ways that we can adjust care. Most of those last 3 things, the semaglutide, the icosapent and the colchicine, are primarily for people with established disease.
Okay, so we'll move on from my case study to another one that might be relatable to a certain section of the audience. But just quickly, so from what I heard there, I could consider a statin, PCSK9 inhibitor if I could afford it. Sounds like maybe slightly better tolerated, but more expensive. And then aspirin for someone in my context, or not really?
You're asking really hard questions.
Hey, you said you're sending me the invoice.
I know. In general, so that's where I would want to see imaging before I recommended aspirin for you. I do have young patients who come in and say, my mom or dad died at 32 from a heart attack. And before they've said anything else, I already, in my head, they're on a statin and an aspirin. Because now, if, for example, there's some genetic factor that predisposes you not just to atherosclerosis, but atherosclerosis that's prone to destabilizing, I don't know, that's a pretty profound history. It's complicated. It's hard to rely just on history. But I tell you, when you're in you have to ask yourself what you're going to do when you're wrong, because you're always going to be wrong, right? I mean, hopefully you're right more than you're wrong, but there's always going to be times where you made the wrong decision. So you have 2 decisions here, drug or no drug. In the case of statin, decide whether to use the drug. If you give the drug and that person is doing great and they didn't need it, worst case scenario is maybe they're having side effects and you're wasting time having conversations with someone who probably doesn't need to be on the drug in the first place and whatever. It's just time. But there's no irreversible bad consequence to having taken it. But if you opt not to take the drug and you're wrong and they have enough atherosclerosis to have an event and their event is a catastrophe, you missed the opportunity to take advantage of that drug. The same scenario is with the aspirin. So you have to think about that scenario when you're wrong, not when you're right, but when you're wrong.
How reliable is measuring CT angiogram kind of over time and determining progression? So like if I was to go and do one today and I said, look, I'm not going to do a statin, but I'll do another CT angiogram in 5-10 years and you let me know if I've progressed.
I don't want to say the wrong thing. I'm definitely not an expert in that, but I think that's a science that we don't have a lot of data yet. I can tell you people in my field have a lot of bias about what to do with that information, but I think that's something that really is ripe for more study. And I can give you some names of people if you wanted to really do a whole conversation about imaging, people with far more expertise in this than I have. Yeah.